This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you.
This is going to be Chapter 5, Errors in Conduction, and we're going to be speaking about tachycardias. So, key concepts. Upon completion of this chapter, you'll be able to understand the effects of cardiac output equation and coronary filling time from heart rates that are too fast. Reentry as a macrocircuit or microcircuit, and how it's the most likely cause of tachycardia errors of conduction. Mechanical, pharmacological, or electrical treatment options. And chief concerns in this is crucial issues with errors of conduction. So, make this as simple as I can. Too fast of the heart rate does not allow for appropriate filling of the ventricles. So at the point that it gets 150 beats per minute, there is not appropriate filling. Frank Starling's law is not coming fully into play, and it reduces the amount of cardiac output. Now this can cause hypotension. This can also cause chest pain or cardiac symptoms. Too slow, we can get the same problems, and this would be less than 50 beats per minute. We generally consider the treatment ranges. If it is less than 60 or greater than 150, then the paramedic's going to have to do something about it or explain why he didn't. So a bradycardia or a tachycardia. Reentry phenomena. Return passes a depolarization through a structure, and some things have to be in play for this. Pass through the structure once already. Causes of reentry phenomena are, there's a bunch of them. So they could have a multitude, they could have a congenital abnormality, they could have something like, in the narrow complex, Wolff-Parkinson's-White. Conditions that must exist: there must be an available circuit, the pathway for the impulse, and an alpha circuit must have a slowed conduction. And I got a picture of this on the next slide here, which is this right here. And this is a PAC, or premature atrial complex. Now, this pathway is slowed, but this thing just so happens to have an alternate pathway. And that means both ways. So, does it make sense that they could very easily be reconducted and essentially formulate 2 beats from what was one stimulation? So we could easily double the heart rate with this configuration if you had this congenital malformation or a fast pathway. And this is called a reentry phenomenon. Essentially, very simply, what occurs is we get some form of regurgitation of the electrical stimulus that just occurred. So we may be getting information from the top, but we also may be getting secondary information from a reentry circuit, if you will. Alright, and these are rhythms usually attributed to an error in conduction. PAT, or paroxysmal atrial tachycardia, atrial flutter, Wolff-Parkinson's-White syndromes, Long-Ganog-Levine syndrome. We'll talk about that on the next slide a little bit. Just a reentry pathway. Junctional tachycardias, VTAC, both from one location monomorphic and multiple locations polymorphic, and ventricular flutter. And we'll differentiate the 2 types on this. Atrial fibrillation and then ventricular fibrillation generally come from a microcircuit. These are all macrocircuit reentry phenomena. Supraventricular tachycardias. And those are tachycardias that originate above the ventricles. Let's go to this. So whenever we're talking about these type of tachycardias, anything that's above the ventricles is a SVT. a supraventricular tachycardia. Now, we generally consider these things to, narrow complex, so less than 0.12 on the how wide the QRS is, and that it is greater than 150 beats per minute. So SVTs, the SA node or reentry tachycardia. So the SA node essentially gets hit the second time. I'll put this in red so that y'all can see. A flutter, which is if we have atria that are up there, and if the ventricles can go into VTach, why can't the atria? And that's essentially their version of VTach is atrial flutter. So the atria start firing from generally a one location, monomorphic location. It gives us a nice little sawtooth pattern. And I'll continue on. So every time that the AV node picks up one of the big F waves or the big flutter waves, it'll fire off. Now, this can range from a tachycardic rate of what would be normal, say somewhere between 60 to 100 beats per minute, and heart rates that are near 300 per minute. So the faster the heart rate gets, the more hemodynamic compromise the patient will have. Paroxysmal atrial tachycardia comes and goes, but again, the multiple focal points are coming from the atria. AV nodal reentry tachycardia, intranodal, and AV reentry tachycardia, extranodal. And there's a couple different types here. I want to talk about these two just a little bit. We'll talk about them here in the next couple slides, but whether it's vasospasm or occlusive, now we're going to talk about penumbra events here as well, and then junctional tachycardias. All of these would be considered a supraventricular tachycardia. Wide complex tachycardia of unknown origin. Important concepts on this is determine whether or not it's VTach. So if we have monomorphic ventricular tachycardia, always check the axis on those. Ventricular flutter is extreme rates. So if we truly have VTach, the rates will be from 120 to 150 per this book. And for ventricular flutter, greater than 200 beats per minute. Now, once we get over 150, or we're upwards of 200, both of those do not allow for proper filling. This is going to put our patient in compromise. Irregular beats, and then we can also have the polymorphic version, which essentially from a lead 2 perspective, let's just go to the board for this. We look at lead 2, a 60-degree camera shot, positive electrode down here, negative electrode up here. How the ECG machine works is if it's above the isoelectric line, it was headed towards a positive electrode. And if it's below the isoelectric line, it was headed towards a negative electrode. Well, at the point that I have pacemaker sites in the ventricles jumping around in a circular fashion, inside the ventricular muscle, it's going to look now, why it looks like this, or why I have this telltale pattern here, is as it closer lines up with this plane, the amplitude is going to increase. As it gets perpendicular to it, the amplitude is going to decrease. So, polymorphic VTach, the number one cause of that is a congenital long QT syndrome, which means the QT interval is too long. It allowed the ventricles to think outside the box or provide another pacemaker site. History. Considerations. Any kind of precipitating factors that might be in play, any kind of temporal events, the mnemonic OPQRST, what time did it onset, did anything make it better or worse, was there any pain, and what's the quality of the pain, is it radiating anywhere, severity, on a scale of 1 to 10, 10 being the worst pain you ever felt in your entire life, what do you think this is, and then timing. What symptom complex are we dealing with? Have you had this before? And if you have, has anything brought it on? And do you have a past history of this? So patterns for tachycardia, this is what we generally see in them. That we have about 96% of them that say that they have palpitations or they have chest or neck discomfort. 47% says they have difficulty breathing or dyspnea. Dizziness in about 75%, syncope in about 20%, unexplained fatigue, unexplained diaphoresis, I just got sweaty all of a sudden, and about 13% of them have nausea. On examination, any type of procedures, cardiac examination, signs of heart failure, diagnostic information that might need to be done, 12-lead, capnographic waveform, good vital sign assessment. If we're going to do a vagal maneuver, please be sure most services do not do a carotid massage because of possibility of bruits. If there's bruits in there, we could break them free and cause a stroke. We should do a risk versus benefits assessment on this. If they have a history of hypercholesterol anemia or high cholesterol, they have a precipitating factor that might lead to plaque built up in their vessels. Valsalva maneuver increases intrathoracic pressure. All of the vagal maneuvers increase parasympathetic tone. Whether it be carotid massage, bear down without passing any materials, blow on a syringe for me, or try to take a deep breath and then pop your ears by holding your nose. Atrial flutter are going to be things that we can correct by this. AV nodal reentry tachycardias, we might be able to correct by Valsalva maneuver or vagal maneuver. AV reentry and junctional tachycardia. So essentially, the SVTs. The easiest way for the doctor to figure this out is by ambulatory electrocardiography monitoring or a Holter monitor. They send you home with a monitor that records your heart rate and your EKG for 24-48 hours, and then they can see whenever you went into these things. Wide complex tachycardia. Important concepts. It could be VTach if you're seeing a wide complex tachycardia. Criteria for that's going to be greater than 0.12 seconds QRS duration and greater than 150 beats per minute. If it's ventricular flutter, it's over 150. It'll be greater than 200. If they have polymorphic VTach, torsades de points, or some type of an aberrancy, aberrant supraventricular tachycardias versus ventricular tachycardia. The key on this is going to be axis, and this is going to be from 12-lead. A rate-related bundle branch block. A bundle branch block that has a specific need to be in the tachycardic ranges because of cardiac output issues. It's going to look wide and aberrant. Let's clear this off and talk about that just a little bit more. Here's his differential diagnosis for VTach versus an SVT with an aberrancy. If you have a bundle branch block and you fired off an electrical beat, hit the AV node, and it's trying to transmit to the perception of the lead that's looking at it, it could look something similar to that. Try to identify which bundle branch block you have. You can have high rates because of reentry phenomena up here in the supraventricular area that is making more and more information, multiple atrial tachycardias, junctional tachycardias. All of these can cause something that would look similar. Now, this is going, if this rate is greater than 150 beats per minute, and you have a bundle branch block that looks like that, your QRS duration is also going to be greater than 0.12. Very simply, determine your axis. If it was supraventricular and is headed in the right direction, your axis should either be normal or normal variant. If it isn't headed the right direction, it'll probably be errad. Assessment. Sudden onset of neurocomplex tachycardia. Autonomic nervous system stimulation, so like a dumping of catecholamines could get your heart rate to go in, suggestive of AV nodal reentry tachycardia. So this would be a reentry phenomenon that would hit the AV node the second time, double the heart rate. AV nodal reentry tachycardia may be difficult to treat because the patient goes into cardiovascular collapse every time it occurs. There's not enough atrial kick or ventricular filling to accommodate for the rate change. Medications to treat dysrhythmias can also cause hypotension. Things like Cardiazem, Verapamil, Amiodarone, all can cause hypotension. In treatment, important concepts. What kind of reentry circuit do I have? Is this an SVT or a VTAC? What medications? Is there going to be a possible untoward effect? The medications that I'm going to use need to reduce conduction velocity or reduce my action potential options in the ventricular muscle, and we're going to talk about them here in just a second. Vascular access to spread the net in case something goes bad. And then, is my patient stable versus unstable? If they are stable, then we should try some pharmacology. If they are unstable, then I'm going to do synchronized cardioversion, very simply. And is the tachycardia complex, is it wide or narrow? If it's wide, it's going to change my pharmacology options. If it's narrow, it's also going to change my pharmacology options. So let's talk about that on the next slide here. So let's do this one first. So very simply, we're going to determine stability off of blood pressure. So if they are stable, this means they have a blood pressure greater than 100 millimeters mercury systolic. If they're unstable, they have less than 100 millimeters of mercury systolic. So the next question that I have, first one's out of the box, is it wide or narrow? If it is narrow and it's regular and it's stable, I can try the vagal maneuvers to increase parasympathetic tone. If that doesn't work for me, this is narrow complex still, then I would try adenosine. If it's irregularly irregular, this would be things like AFib and aflutter. Then these are my medications of choice. I'll explain that here in just a second, so we're going to come back to this. If it is regular and it's wide complex, amiodarone is my drug of choice, 150 over 10 times 3. Lidocaine is the next second choice if they're allergic to amiodarone, but amiodarone has the highest efficacy. Procainamide, third on our list, and then if it still doesn't work for it and they're still in it, we could try a synchronized cardioversion. If it's irregular and wide complex, I start off with amiodarone. If it's really irregular, like polymorphic, I could try some magnesium, 1 to 2 grams over 1 to 2 minutes. And then if that doesn't work for me, I can go to cardioversion. If they are unstable in any form or fashion, cardioversion is the ticket. For atrial fibrillations, it's suggested that we start at about 50. For any other ones, an SVT, a VTAC, we should start at 100 joules biphasic energy. Let's talk about this guy right here a little bit and why calcium channel blockers have the highest efficacy. So, calcium kicks off every muscle contraction. It also helps increase the contractile force strength in the middle of the cardiac cycle. So if your entire atria are fibrillating, where would you apply control? And the answer is the AV node. Since calcium still initiates the contraction, if I put on board a calcium channel blocker, it would initiate me some control over the AV node and slow conduction velocities through the AV node. That's why we would use Cardiazem. Cardiazem is a second generation medication. First generation was verapamil, but it made our patients very, very hypotensive. Cardiazem at high doses will still make your patient hypotensive, but it's less invasive. It'll work more on the AV node than it does on the tunica media of the vessels. And the vessels themselves, that's how you get them to relax, is through a calcium channel blocker, or one of the ways, where the vessel is much larger. Very simply, verapamil used to bring this about sometimes before it would adjust the rate. Cardiazem's a lot better and will start on the rate before it adjusts the size of your vessels. Amiodarone has a calcium channel blocker in it as well. However, amiodarone at some point can make your patient hypotensive. Pharmacological interventions. So for wide complex tachycardia in this order, this is going to be our efficacy of choice, which is going to be amiodarone, then lidocaine, then procainamide. So if they're not allergic to amiodarone, amiodarone is our drug of choice. Amiodarone has its effects on the action potential. It affects the sodium, potassium, and calcium channels as well as beta-adrenergic receptors. Very simply, amiodarone is like a shotgun for the receptor sites of the heart. So it will calm a multitude of things down simultaneously. Lidocaine is an isolated sodium channel blocker, and so is procainamide. It decreases conduction velocity, reduces the action potential, thereby reducing the possibility of aberrant firing from ectopic sites. Irregular wide complex tachycardia is, again, this is our multi-use antiarrhythmic. Amiodarone's at the top of our list. If we think it's polymorphic, then magnesium. Magnesium displaces calcium ion, relaxing smooth muscles. So very simply, if they're in polymorphic V-tach, the magnesium sulfate will assist in converting them through pharmacology. And then last choice here is going to be overdrive pacing of a tachycardia. You have to crank up your rate extremely fast, so you have to capture it with the pacer, take them above what they're currently at, and then back them down. Sometimes your patients can't give what they don't have. Regular narrow complex tachycardias, all of these should be risk versus benefit when giving these medications. Regular narrow complex tachycardia, a sinus tachycardia, I would figure out what's giving them a sinus tachycardia. You do not want to give a PE adenosine. If a person is hypovolemic, you do not want to give them adenosine. If they are an SVT and you think it's cardiac in nature, adenosine has a half-life of about 15 seconds. It overpowers the powerhouse or the ability of the heart to generate an action potential for about 15 seconds. It creates a systole for about that long, up to that long as well. Calcium channel blockers block the calcium channels and the introduction of the actual beat. Beta blockers are an adrenergic nervous system, more specifically beta 1 and beta 2. Most of our beta blockers nowadays are beta 1s are selective or beta 1 specific, so that the heart doesn't have the ability to generate automaticity from the autonomic nervous system receptors. And then last but not least, if we don't know what's wrong with it and we want to calm it down, amiodarone is a good choice. Now, on all of these, please ease your patient into a therapeutic index. If you push this stuff fast or you drip it fast and don't keep them therapeutic, very simply, they could become hypotensive and go south quite rapidly. Atrial fibrillation and AV reentry tachycardia. Pre-existing AV reentry tachycardia. It's extremely fast heart rates can occur. The ventricles can be besieged with impulses after impulses and sustained heart rates of over 250 beats per minute. This can lead to myocardial fatigue, irritability, and ventricular fibrillation. We have to apply some control over fast heart rates. Do not use calcium channel blockers. Consider amiodarone or procainamide. If they have a wide aberrant AFib with RVR, amiodarone's the top on our list. The next guy on our list is going to be procainamide. Evaluation. Patient is unstable when tachydysrhythmias are caused. When they don't allow for proper filling, they have decreased cerebral perfusion, decreased coronary perfusion, they may have chest pain, decreased pulmonary perfusion, systemic hypoperfusion, or other signs of shock, cool calamity diaphoresis, altered LOC. If they're unstable in any form or fashion, we need to cardiovert them. A synchronized cardioversion, depolarizes the heart artificially. What this does is it allows it an opportunity to reset itself. Cardioversion and AFib should be avoided unless absolutely necessary. And the reason being, if there's stagnant blood that's been in the left atrium, you could have created a clot. And this clot, and now if it gets spit out, has a high chance of giving a person a stroke. So you could actually give them a stroke by cardioverting them. Again, risk versus benefit. Failed cardioversion. Mechanism may be an error of automaticity. So after repeated cardioversions, you still have a problem. You may find yourself one day in a scenario to where you have to start mixing medications with the cardioversion. Please refer to the treatment algorithm for these indications. Disposition. Patients with tachyarrhythmias need to be transported to the hospital. Further medical treatment, antidysrhythmic drugs, and or anticoagulants if they do have possible clots built up in there. Helpful to transport them to a cardiac center where they have an electrophysiology lab or interventional cardiology suite. In conclusion, errors of conduction that cause tachydysrhythmias may produce subtle patient complaints. A astute paramedic will pick up on these complaints and look for the tachydysrhythmia. References for this session were taken from Myers Professional Paramedic Volume 2, Medical Emergencies, and Maternal Health and Pediatrics, Del Mar Learning. If you have any questions regarding this section, feel free to give me a call. My name is Roy Smith, smithr@emsa.net, or 405-219-7613. Thank you.